Thank you.
Are you all right there, Lisa?
I am. So thank you very much. I was just waiting for myself to come live. So welcome to our first session this afternoon, where, as Vivian's indicated already, we're going to be talking about the burden of treatment on patients, and in particular explore some of the implications of remote care or telehealth for those burdens. To start off our first session, I am delighted to introduce a talk by Frances Mair. Frances is the Norrie Miller Professor of General Practice and the Head of General Practice and Primary Care at the Institute of Health and Wellbeing at the University of Glasgow. She is going to talk about the burdens that treatment can place on the patient. Over to Frances, and then we'll be back for a panel discussion.
Thank you to the organisers for inviting me along to talk about burden of treatment. I'm going to start by talking about the context that we work in, then define burden of treatment and discuss a bit why it is important for patients, practitioners and healthcare systems, and then conclude with a few thoughts about implications of burden of treatment in the context of remote care. I'd like to start off by acknowledging my colleagues who've contributed to this body of work, especially Katie Gallagher, Carl May and Victor Montori, and the wider International Minimally Disruptive Medicine Work Group. I'd also like to acknowledge our funders who have supported this programme of work. Okay, chronic disease and multiple chronic diseases, particularly multimorbidity where people have 2 or more long-term conditions, is the greatest healthcare challenge facing us this century. So we no longer have people who have just low back pain or respiratory problems or diabetes, but we have people who have all of these combinations of conditions together, along with other conditions like depression, anxiety, chronic pain of all kinds. And so they end up on lots of medications and treatments. And this is the big challenge that we're facing just now, the big global challenge for healthcare. So we have healthcare systems, however, that have been designed to deal with acute problems, and they do that very well. So if I have my crushing chest pain, then I want to go in my ambulance to one of these fantastic hospitals. Here a picture of the Queen Elizabeth University Hospital, a new hospital in Glasgow where I work, the biggest in Europe, and it's got all the modern technology that you'd want. Equally, if I'm in a car crash and have a major trauma, I'm delighted to be airlifted there and I know I'm going to get first-class care. However, I do think our healthcare systems are far less fit for purpose when it comes to managing chronic illness, and especially people with multimorbidity, if you've got multiple chronic illnesses. And if you take this lovely hospital there in the picture as an example, if you've got disabilities, you're frail and got poor mobility, then it's actually quite difficult to move around. I can say from personal experience, trying to get somebody discharged from there who's a wheelchair user required at least 2 people to do that, because there are very few spots to drop people off who are disabled or frail. You have to walk a long way from the car park to the hospital. You have to find wheelchairs. So it's just not been designed with thinking about the needs of people with disabilities or multiple chronic conditions. And the whole healthcare system mirrors that, and it's the same across the piece. And this really matters. I've said multimorbidity is the biggest healthcare challenge, and in 2012 there was a landmark paper in the Lancet, and this is a figure from that paper, and it just makes the point that multimorbidity, the presence of multiple chronic conditions, is not just a problem of older people. And you can see from this figure that it's something that affects younger people too. And it's important to draw your attention to the red line on this graph, which shows that people with the most socioeconomically deprived groups. So the red line are those from the more deprived backgrounds, and they developed their multimorbidity a full decade earlier than their more affluent counterparts. So multimorbidity, international problem, affecting all ages, increasingly common, particularly affects those from poorer backgrounds and less able. So a decade ago, Carl May and Victor Montori and I wrote a piece in the BMJ, and we called for minimally disruptive medicine. And the basic premise of our paper was that poor patients were being increasingly overwhelmed by the treatments and the advice and the demands placed upon them by healthcare systems. and that these patients were being overwhelmed by these self-care demands, this shift of workload from the healthcare sector onto patients and their supporters, and that this was meaning that they could no longer adhere to treatments and that they would therefore not benefit and get good outcomes. And we talked about these overwhelmed patients and the problem of burden of treatment. And we later wrote a piece suggesting that burden of treatment should be an important barometer of quality of care, and that it be something that should be measured. And since we've done this work, there in fact have been 3 measures of treatment burden developed. But we think this is something that should be more of a target for healthcare systems when they're looking at quality of care. So it's important to distinguish illness burden and treatment burden. So what do we mean? Illness burden is something everybody knows about, dealing with the symptoms of an illness, the shortness of breath, the fatigue, the chronic pain. But treatment burden is referring to the work that people have to do to understand their illnesses and the work of self-managing, of taking the tablets and going for treatments, and also dealing with their interactions with healthcare professionals. So we've done quite a bit of work to try and define and tease out the different components of treatment burden. And you can see from this figure that we have 4 basic areas. The first is learning about treatments and their consequences. And patients and their families have to work ever harder to get an understanding of their chronic conditions and its treatment. And as we advance in healthcare and we develop new medicines, but also new technologies, this becomes more challenging and more work. If you think with patients with heart failure, for instance, not only do they have to take a vast array of medications, remember to take them, and gain an understanding of why they're taking them and side effects and when to report problems to health practitioners, they also have to deal with things like devices like implantable defibrillators and understanding the implications of that for them now, when they might be reasonably well, but also as their condition advances near end of life and what might be the implications for deactivating such devices. So there's a lot for patients to learn. Then there's the engagement work that people have to do. Engaging with friends and family to get help to go to clinics or to arrange for medications to be collected, but also the engagement work with professionals to get onward referrals to other specialists and other types of resources, to access social services, to access aids for the home. Then there's the work of operationalizing self-management, having to attend appointments, having to take the medications, having to endure the side effects, having to enact the lifestyle changes that are recommended to you, having to undergo lots of investigations. And then finally, the work of monitoring the treatments or monitoring your condition. So people are increasingly being advised to monitor their blood pressure, to self-monitor, monitoring blood sugars, and to do other activities to monitor their condition, and so that they can report back to healthcare professionals and get advice and optimize the control of the condition. But equally, people have to reflect on the management and the treatments they're taking and say, are you going to continue taking this or not? Or reconfigure them to meet their needs. If you're on a diuretic tablet that makes you run to the toilet frequently, you might say if you're going out to a meeting or going somewhere where you'll miss out your tablet so that it enables you to carry out your activity of everyday living. So people often reconfigure their treatments to make them work for them. And we said that we need minimally disruptive medicine and less structurally induced non-compliance, because we really believe that the way we treat patients, the fact that we overload them without consideration of their capacity to undertake the tasks that we give them, that we lead to people not being able to adhere to treatments, and therefore that they get poorer outcomes. And to improve healthcare outcomes, we really need to decrease the burden of treatment, improve patient understanding, and therefore increase adherence and give the opportunity for people to benefit from the treatments that we're prescribing. So treatment burden can be as a consequence of the healthcare workload that we place on people, the treatments that they have to take, the lifestyle changes they have to endure, but it also can be related to care deficiencies. And I took this image of 1 issue per visit off of Twitter, and it was a lady who was complaining that she had multiple health problems, and gosh, did she need to make 6 appointments to go and see her GP because this sign had been up in her GP practice. And she's right. That is a ridiculous system that somebody has to come in with 1 problem when people with multiple conditions will have multiple problems. But equally, as a GP myself, I can see the difficulty. You can't deal with 10 different problems adequately in 10 minutes. So we have structures and ways of working in healthcare that make it difficult for us to decrease treatment burden. So these are structural issues in the way we organize care. And you need time to deal with multiple conditions and multiple problems. So I had someone who came into my practice a few months ago, and he came in just for a rash, and he was on about 20 different medications, and he had a number of different illnesses. He had hypothyroidism, depression, chronic pain. He'd had coronary artery disease and had had a stent put in. He'd had a stroke, so he was on a lot of treatment. And when I said, gosh, you're on a lot of medications, he said, oh, no, I'm not. I said, well, you're on all these tablets here. And he said, no, I'm not. I stopped taking them. And I said, well, how do you feel? And he said, I feel terrible. And I'm not surprised, because he had an underactive thyroid. He'd stopped taking his thyroxine. He had a lot of problems with depression. He'd stopped all his antidepressants. So we had to spend time talking about the treatments and why he'd stopped taking them, and so on and so forth. Fortunately, he was the last person in my surgery that morning, and I could spend that time with him, but I couldn't have dealt with that in 10 minutes. And this is a quote that I've kept as a patient who is no longer with us. He was a patient with advanced heart failure. We were asking him about the care he'd received. He's a Scottish patient, as you can see from the quote, and he said this sentence, and I thought it really summed up the problems that we face. I feel it's for the institution, it's not for the patient. Everything is geared for smooth running. That means it's from the hospital point of view and not the patient's view. Right or wrong, what do you think? And I thought it was really quite tragic that in his last weeks of life, that was how he felt the healthcare system was treating him. And we see this all the time, that healthcare systems are often configured to make the system work better. Again, I work in a general practice in a health centre. The health centre has a treatment room. The treatment room is run by our local health board. Recently, they got rid of all the same-day appointments. Same-day appointments are a bit inefficient because you might not fill them all, so you might not get as many patients seen as you would like. But for patients, it's really a tragedy to get rid of those same-day appointments, because somebody comes to see me, I think they have heart failure, I would normally send them to get a blood test to right there on the spot, but now they can't do that. Now they have to make another appointment to come back and schedule for that test. But that change is made without thinking about the patient experience and what it means to burden of treatment. So our message really is that we need to reduce the burden of treatment. We need to make things simpler. We need to encourage coordination in clinical practice and improve communication. But we also have to prioritize from the patient perspective, taking into account capacity issues. And I'm going to talk a little bit about this now, this issue of patient capacity. But we also have to acknowledge comorbidity in our clinical guidelines and in the way we manage people. So thinking of capacity and people's ability to deal with any given level of burden of treatment. People will vary in their capacity to self-manage. We all know of people who've maybe got 5 conditions, they're on 20 medications, and they're actually managing okay. But we might have somebody else who's got a similar pattern of conditions, similar treatments, and it's just a disaster. Things are going very badly. Why is that? Well, people will vary in their ability to cope with those conditions, to cope with the treatments that are being prescribed. And there's lots of factors that affect people's capacity. And capacity is not a fixed thing. So it might be that capacity changes over time. Somebody might be managing their complex multimorbidity and all their treatments very well because they've got a supportive partner. A year later, that partner might have died or become very ill themselves. They no longer have that support, and then they can no longer cope with their burden of treatment. There have been some theoretical models that have been developed to look at burden of treatment theory, and the cumulative complexity model, which talks about the interplay between burden and capacity. Here on this next slide, you see a figure represented, the cumulative complexity model, and you'll see the patient workload at the top there, the demands of self-care, and the patient capacity issues down below. And they come together to affect healthcare outcomes. Now, these are quite abstract ideas, and so I thought it would help to talk about a patient, to make it a bit more concrete, a bit more easy to understand what I mean, what I'm talking about. So I'll just give you an example of John. That's not his real name, but it's just to outline some of the issues. So he has a lot of personal health conditions. He actually started off with polymyalgia rheumatica, a condition which required him to be prescribed high-dose steroids. Those high-dose steroids led to him developing diabetes, osteoporosis, and hypertension. Over time, he then developed atrial fibrillation, a regular heartbeat. And then he had an episode of rapid atrial fibrillation, which led to him going into acute heart failure. He was admitted to hospital and was then found to have underlying coronary artery disease and peripheral vascular disease. When he was attending a peripheral vascular clinic, he had a transient ischemic attack, and they found he had carotid artery disease and he had to have a carotid endarterectomy. He has a lot of self-management work. He has to arrange to get lots of medications. He has to take 10 different medications at different times of day. He has to endure their side effects. He has to attend lots of clinics and get investigations. He's been given lots of advice about increasing his physical activity, changing his diet. But he also has other problems he has to manage. He has a mother with dementia. He has a father who's cognitive impairments and also has AF and has episodes of blackouts where he'll be called to a bus stop or be called to a hospital because he's collapsed outside. He has an older brother with COPD and poor mobility and learning difficulties. He also has a daughter of 8 and he wants to have some fun. And he's very fortunate to have a supportive wife who actually eventually has to give up her work to retire early so she can help support him. The healthcare system focuses very much on John's personal health conditions and maybe a little bit on his self-management work, but it doesn't think about his life world or these things that might impact his capacity to self-manage. We need to think of patients holistically, thinking of the person and their ability to manage the conditions that they have, and think about how we can help them. So we really think about capacity as having a number of different domains. So the personal attributes and skills, somebody might be very resilient, but there might be somebody else who's got low health literacy. So this will affect their ability to cope with treatment burden. People might live alone and have no support network to help them to go to appointments or organize things. Somebody might have quite a big support network who can help them. Life workload, we always think of the patient as being the center of everything. Well, that patient might be the person pushing the wheelchair and might also have that as another thing that they have to deal with. Or they may have a very busy job that they're overloaded or other caring responsibilities. People will vary in their physical and cognitive abilities. Some people may be very fit and well and very able to manage. Other people will be frail and have mobility problems, and getting to the hospital in 2 buses is a real challenge. Or they may have forgetfulness problems, and that might be related to the conditions that they have that make it difficult for them to remember things and remember appointments. Financial status clearly does make a difference. If you've got enough money to get a taxi to that lovely hospital, it's a lot easier than trying to get 2 buses. And environment also matters. I've got 2 pictures here. They come from Glasgow. The top one is Easter House in Glasgow, one of the more deprived areas in the city. And the bottom one is Rookenglen Park in East Renfrewshire, one of the more affluent parts of the city. There's a 15-year difference in life expectancy in men in the more deprived area than the more affluent. And you can imagine why. If I give a patient advice to go for a walk each day, is it easier to do it in Rookenglen Park, which looks lovely, or in Easter House, where the flora and fauna around you is not very appealing and there may be safety issues? So this is all very well, but does it make any difference to healthcare outcomes? Well, a while ago, we undertook a systematic review and we looked at interventions to reduce readmissions, 30-day readmissions, in people who'd had a medical or surgical admission. And we found that those interventions that increased individual capacity were significantly more likely to reduce readmissions. We do think these things really matter. Rear Admiral Grace Hopper was the first female admiral of the Navy, and she said something that I think really applies to healthcare today. She said the most dangerous phrase in the language is "we've always done it this way." So much of how healthcare is provided is because of tradition, of the way we've always done it. I think we need to think differently. We need to reconfigure our services. We need to reimagine them so they're better configured to deal with people who've got multiple chronic illnesses. I think health systems need to change. Simply exhorting health professionals to do better is insufficient. We often say patients don't understand their problems well enough. We say GPs or clinicians in hospital or nurses need to explain better. But when you have a 10-minute appointment system, it constrains that. So we need to think about how we enable healthcare systems to enable healthcare professionals to do better. We need to make health system incentives realign to facilitate and promote more person-centered care. We need healthcare to become simpler. It's really difficult to navigate. Even for me as a doctor, it's very difficult. And we need to make it more careful and kind and less hard work. So I believe our focus should be on developing approaches that are better tailored to patients' needs based on their capacity and their personal goals. And I think that a one-size-fits-all approach is unlikely to work. And I think that's really important when we think of the potential of remote care and the potential it has to tailor care for people's needs. A one-size-fits-all system is unlikely to be effective. I think about implications for practice, something we can do right now in our everyday practice with patients. When we're giving people treatments or advice, is to ask them two simple questions. Do you think what I'm asking you to do is the right thing for you? Because if people don't buy into what you're telling them to do, they aren't going to adhere. And so all the efforts are wasted. So you need to check, does it seem the right thing? And then if they think it's the right thing, the follow-up question needs to be, can you really do what I'm asking you to do? Because there's no point sending someone away with 10 medications and all this lifestyle advice and all these instructions if they won't be able to remember it, if they won't be able to intend, if they won't be able to manage. So I think those are the very clear implications for practice right now. But I think it's a question of system change and how do systems, healthcare systems, need to be made kinder for patients. And just a final few thoughts about burden of treatment and remote care. Can digital health help? Well, we think it's a panacea, or at least many people, especially policymakers, propose it as a panacea. And I think it has great potential. But can it help burden of treatment? It depends. My nightmare scenario is that there'll be a poor patient sitting there with his telecare unit for his diabetes, a different telecare unit for his lung disease, a different telecare unit for his hypertension, and a different telecare unit for his heart failure. And none of them will talk to each other. And the patient has to repeat some things that are needed for one in another. That's my nightmare scenario. So we need devices and applications and workflows and systems that are going to lessen burden of treatment, not add to it. And we need to make sure that they're available to people who might be less digitally able, because we don't want to widen health inequalities. I think our digital health and remote care interventions need to be tailored to meet the needs of our varied population with multimorbidity. And it is possible to do this. I've been involved in developing an app for people with low back pain. It uses artificial intelligence to provide personalized, tailored information and support on a weekly basis. So these types of systems do exist. And I just think we need to think very carefully about what we're going to invest in terms of remote care, because we want remote care to lessen the burden of treatment. We have a real opportunity, but if we follow remote care doing the same things as we do now and just making it digital, then we'll have a really big missed opportunity. Anyway, those are my thoughts. Thank you very much for listening. I hope this has been of interest, and I hope it helps stimulate the discussions over the course of the day. Thank you very much.
Thank you very much, Frances, for that wide-ranging and stimulating talk. Frances joins me now with our other panelists, who I'm hoping are going to join us momentarily in this room. Here they are. Thank you. So welcome. If I can introduce everybody. Firstly, we have Natasha Patel, who is going to speak from a patient perspective. Natasha had COVID severely, which meant that she needed to attend clinics virtually, was involved in monitoring her own oxygen as well as other biomarkers. And she found this to be a great comfort to be able to have her care within her own home, but also burdensome to take that responsibility. We then have Emma Doble, who is a patient editor at the BMJ, who's going to speak from the perspectives of managing diabetes with a newborn baby in the pandemic. And then Dr. Gurjit Chhokar, who is a consultant in elderly medicine at Leeds Teaching Hospital, who works particularly with frail elderly patients with Parkinson's disease, and is going to share his insights into how he has used remote consultations to lessen the burden of treatment on his patients. And finally, on this panel, we have Natalie Richards, who is a researcher with me here at this institute, who's going to be posing some of the audience questions in a minute. Firstly, Natasha, if I can come to you first, could you explain what this concept of burden of treatment means to you as a patient?
Sure. So my experience was, obviously, when I was incredibly ill with COVID, originally I thought it was an asthma attack, so I went into hospital, and then I received the positive test 2 days later, and then I was effectively discharged to the virtual clinic. So it meant that the responsibility was on me to ensure that I inputted data at the right intervals in order for clinicians to view my data in time for them to potentially feed back to me. And so that at times was helpful because it meant that I didn't have to leave my home. It meant that I obviously didn't have to be in hospital and risk potentially contracting other things. But it also meant that I was left with a lot of my symptoms myself. And I appreciate that not everything can be treated in hospital and it's not appropriate. But when I had the brain fog, the fatigue and shaking and things like that, it felt quite daunting to ensure that I was, for example, taking my own temperature. It might not sound that tricky, but when you're struggling to breathe and you're breathless and you're holding your breath to make sure you're holding the thermometer yourself and then inputting the data accurately, it's a small thing, but making sure that I did it 3 times a day felt like quite a lot. And especially with the oxygen saturations, I think as well, managing my concerns around seeing a number that was say 89, 90 at times, and then reminding myself of what I needed to do in order to, if it doesn't come up after I take the appropriate action, then what do I need to do next? So I think it was the burden from my perspective was remembering, okay, what's my next step? What things do I have to look out for? And then amongst all the brain fog and fatigue, thinking, do I want to bother someone if taking a few deep breaths fixes this, or is it bad enough to ask for help? So I think, again, the onus being put on me as a patient, not wanting to make a fuss, but also knowing that if I leave it too long, then the intervention would have to be greater, as in the demand from healthcare systems would be much greater if, for example, I needed an ambulance to come and get me rather than my wonderful brother driving me to hospital.
Brilliant, thanks so much. I'm going to come next to Emma. Emma, you're a patient editor at the BMJ. Could I ask you to give your thoughts on providing care remotely via telephone or video consultation and how that alters the burden of treatment?
Yeah, definitely. I mean, certainly in my experience living with diabetes, it's been a huge shift really in how I've received care, because all of a sudden, rather than me having to come to a hospital and deal with all of that, you know, challenges of getting there, parking and all the rest of it, actually the burden has now shifted. And for me, you know, now when I receive all my care through a telephone call or a video call, actually the conversation that we have, the power dynamic of that conversation has completely shifted. And that's largely because rather than when me going into my appointments, us relying on a blood test and all these kind of biomarkers that I've had done at the hospital, what we're now looking at is my online records from my pump, my insulin pump, and my blood glucose monitoring systems. So the fact that both myself and my doctors can look at those at the same time, it has completely changed the way that we have a consultation together. And for us, certainly it's been really empowering to have that shift now. It's really reduced the burden for me, because that was information that I had. It's what I find most useful to talk about my diabetes and to have those decision-making conversations. And it's really nice to go into my appointments feeling like I'm really informed and that I have the information that I need to have that conversation with my consultant.
Brilliant, thank you. I think reflecting on those two different experiences, I wonder if there's something which we might pick up later in the discussion around the difference of a chronic illness and something more acute, and whether there are different learnings that we need to pull out from those. Gurjit, I'm going to come to you next. Your patients are elderly and frail. Could you tell us about your awarenesses of the burden of treatment for them, and some of the steps that you took, I believe even before the pandemic, but certainly during the pandemic, to try and lessen the burden of treatment for your patients?
Yeah, thanks, Lisa. So I've got some notes that'll take me about 5 or 6 minutes. So if I'm going a bit long, just tell me. But I think when I started as a consultant, my clinics were set up, as Professor Mair said, just how things have always been done. And we're trying to look after people who have daily fluctuations, an illness that affects them different ways every single day. And we're trying to give 4 monthly or 6 monthly checkpoints and saying, consolidate all your problems and wait for that appointment. And I think, seeing people physically struggle, like quite literally drag themselves to my clinic to see me, and the more advanced, Parkinson's gets, the less the medicines can do. So often I'm just saying, I'm really sorry that, there's nothing else I can add. So to have somebody go through all that physical, burden, come to see me, for me to just say, I'm really sorry, there's nothing else I can do, just didn't feel like the balance was right there. I think the other thing I have to remember when I'm doing clinics and I diagnose somebody with Parkinson's, I'm also often diagnosing their partner as becoming a carer for the rest of that person's life. And that can become quite complex because the burden of treatment might actually affect them and not the person with the diagnosis. And sometimes you have to figure out whose goals it is that you're trying to achieve. So basically saying to somebody, okay, you've got this symptom, here are the medication changes I'm going to recommend. And going back to Professor Mair's question about, do you think you can do this? Do you think you can tolerate this? I think often the answer is, I don't know, like I need to try it to know. So they kind of just need somebody to be there, not to say, give it a go and see me in 4 months, because I think the answer there, I'm going to risk that, thank you very much. What they need is somebody to say, well, I'll give you a phone call, we'll talk it through in more detail, we'll do things very slowly and incrementally, and I'll be alongside you the whole way. So that's where I think remote care can actually help. It can move us from that, on the scale of coping threshold, it can move us from the fragmented healthcare more into that sort of social support, and we can bridge the gap and sit on the middle of the scale a bit. And single disease conditions do that a lot with like epilepsy nurses or diabetes nurses. Often we ask them to be that social support, but I think remote care can allow us to do that. So about 3 years ago, I changed one of my clinics a month from a face-to-face clinic to what we call the palliative care MDT. So I work with 2 of the hospices in Leeds and a Parkinson's nurse, and we try and do everything by telephone. So there's no waiting lists. It's phone calls as and when the person needs them, or if we haven't heard from them for a while, we'll pick up the phone. And then if they do need a face-to-face appointment, we'll go to them or see them in a location that's more convenient, rather than, all the car parking and things like that here. So we can fit it around there or the carer's needs. And it allows you to do real-time support with people. So when they don't know whether it's the right thing, you can guide them through and deal with things each day. I guess, patients and carers do that. They make decisions every single day, and sometimes there can be guilt attached with that. Sometimes there can be a lot of anxiety. So the common example of not taking frusemide that morning when they came to clinic because they didn't want to wet themselves, that's really sad. And we can be there, and it's a quick phone call. They don't have to wait 6 months. Parkinson's is really difficult because as you increase the medications to help somebody move, what you say to them is, I'm really sorry, but this could cause hallucinations, it could cause delusional behavior, confusion, or you might actually go the other way and get hyperactive movements. And if you say that to someone, you can guarantee they'll say, no, I don't want that. So it's really important that we are there sort of each step of the way and be able to intervene before crisis occurs, because obviously that does then lead to readmissions and hospital stays. So I've been doing the remote clinic for a while before the pandemic hit, and obviously when the pandemic did hit, outpatient services couldn't be conducted. So, you know, for decades we'd been setting up clinics so that people depend on us, and then all of a sudden when the pandemic hit, it might be a bit strong, but we sort of abandoned them. We said, we're sorry, you can't come. So even if we had face-to-face, Parkinson's was on the clinically extremely vulnerable list, so people would have been attending under extreme fear of catching COVID, and that just didn't feel right. So we were able to pick up the phone and just talk to people. And what struck me is that a lot of people's symptoms were way better during the pandemic than they ever were when they came to see me face to face. And I think everybody had that, you know, oh, you'll be way too busy, there's people who are worse off. And they might have been downplaying it a little bit. But what we were able to do was offer reassurance and talk to them about what clinically extremely vulnerable might mean, talk to them about why we think that Parkinson's was put on the clinically vulnerable list. And I think it meant that we were more in that social support bracket rather than the being solely in fragmented healthcare. Even managed to do, you know, a new patient review over Zoom, and that was quite a positive experience, because essentially it was the family who were really worried. We're not able to see our dad and we're really worried he's got Parkinson's. So I phoned him first and basically just reassured him. I could see that he wasn't in crisis and that we had time. And I could ring the family and say, don't worry, we've got a bit of time. But then when they were able to form a bubble, they helped their father with a Zoom call. I was able to explain to them what kind of things I would do in the examination and how they could help me. So they were able to describe the differences of stiffness in his left and his right hand to me. They pre-prepared some handwriting, which I used to assess. And, you know, it wasn't my intention to diagnose him on the video call. I don't think I would have done that. But it definitely helped to relieve a lot of stress. And I genuinely think if that had carried on, they'd have resorted to calling 999 and he'd have ended up in hospital unnecessarily.
Thank you, Gurjit. I probably ought to widen the discussion, but you've given us some brilliant examples there of, you know, really kind of worked through case study of how remote care can lift some of these burdens. Frances, could I come back to you and ask you to reflect a little bit on some of the risks and benefits of remote care in relation to burden of treatment? I mean, Gurjit's given some brilliant examples there. I wonder if there are any others or any other reflections from your practice you want to share with us.
Yeah, I mean, I think not just from my practice, I think we've been doing a lot of work with people over the pandemic who've got multiple chronic illnesses and asking them about their experiences about moving to remote care. And in fact, their experiences reflect exactly what people have been saying here. So for some of them, especially those, for instance, with invisible disabilities like chronic pain and fatigue, the not having to drag themselves down to take 2 buses to get to a clinic, which then exhausted them and made them unable to work, you know, or do anything for the next couple of days to recover from a clinic visit, has been fantastic. And they've just said, wonderful. But equally, I've had other people talk about saying, well, you know, the physiotherapy, getting it by Zoom, I found it was useless, you know, and I'm sure you'll get some who'll say they find it very good, but there's a real divide on what people's experiences. And certainly for the people in my practice who, for instance, don't have English as a first language, our telephone consulting and video consulting can be a real problem. Even though we have a language line that we can use, it's just very difficult. So I have some of my regulars who don't speak English who just come down and sit down in the receptionist will say, I've told them it's a telephone appointment, but they're just sitting there. So that's fine, I'll just see them, because it's just too difficult for them to manage. And equally, if you have I have people, and they're not necessarily old people either. I have people younger than me who I've talked about, you know, telephone consulting, things like that. And some people just don't find it just difficult, you know, especially if they've got addiction problems or mental health problems, but they might have other issues that they just feel that seeing someone face to face it makes a big difference for them. And there are some people, again, they don't necessarily need to be older people, younger people as well, who just actually don't have good Wi-Fi or broadband, or even if they have some of these, they just feel they can't use these systems. You know, I had somebody who had a problem with their foot, and we were doing a telephone consult, and I said, well, let's just change this to a video consult. And he only managed to do that because he had somebody else there to help him. If he hadn't had that person there to help him, it wouldn't have happened. And again, sometimes I ask people, email me an image, and some people can do that and others can't. So I guess what I think it's really this need to tailor this fact that one size fits all, and just assuming we can do digital transformation and that will suit everybody is just not going to work. We're just going to widen the health inequalities that we have. But that doesn't mean we shouldn't go down the digital route, because people here have talked about the benefits that they feel. And for some people it is great. You know, why do I have to come down with my broken leg to get a sick line when somebody can actually now just email it to me, and that's much more convenient and much less difficult and things. So it can be really helpful and less in burden of treatment. But I think it's a two-way street, and understanding what's going to be challenging for people and taking that into account, because we kind of just assume people can do it. Yeah. And we're not actually putting in things to help. And I was really impressed with Gurjit's comments about being proactive and following up with people. And I think there have been examples, for instance, of remote care and digital health that have worked when we give people apps and things. And often it's been helped because there's been onboarding or some kind of support to help them. But often these things are rolled out without doing that. So those who are more able manage, and those who are less able do not. And then we need to think about processes, like where I am in my city, you know, people can self-refer to physio. I tell them there's an online self-referral form. Do you know when you actually go to that online self-referral form, you can't actually email it, you have to print it out and take and post it. So how many people have printers? Not that many, really. So that then ends up being a barrier. And I actually think, why? But people just aren't thinking through the steps and what will that mean for any individual. So I think thinking through the steps, what does it mean? And checking, can you do what I'm asking you to do, rather than assuming that everybody can. And for some people, people will say, oh yeah, of course I can do that. That's great. So that's fine. And you've just asked to check, and hopefully nobody's taken offense that you've checked their abilities. But for other people, they're like, you know, suddenly people can say, I can't manage it. And people may not volunteer that they can't manage. It's a bit like not being able to read or not being able to do things, where there's now an assumption that people have these resources. Yet we have so many people increasing levels of poverty with austerity, and people struggling to get food on the table, and therefore broadband. Is that the main priority, fast broadband? And even if you have broadband, do you have the devices that you need? And you may even have these abilities, but people have other things they might be living with in their lives, in terms of children with disabilities, children with attention deficit disorder and hyperactivities, older people they're looking after with dementia. So a lot of self-monitoring tasks can be burdensome. So as was mentioned with by Emma, it can be helpful. You're not having to go down, and it can change the dynamic of control. And for some people, it can be outstanding, and it's definitely really helpful. And I just want everybody to benefit in the same way. And I think we actually need to think very carefully about how we ensure that that happens, and we don't leave people behind, because there's a big danger that there's going to be a significant chunk of people, probably those most in need, who get left behind in this. And I can just see that those health inequalities, that it'll be a 20-year difference in life expectancy by the time I retire, rather than decreasing. And that would be a dreadful lost opportunity.
Thank you, Frances. I'm going to hand over now. Thank you for all of those insights to my colleague Natalie, who has been monitoring the questions coming in from the audience. And we're just going to pose some questions from the audience before we finish. Natalie.
Thanks, Lisa. And thanks to all the panelists too. I'm just going to read out a few questions, and it would be great if one or two provide your reflections. So just following on from what Frances spoke about, we've got a question here from Nicola Gray. Does digital technology increase inequalities? And if yes, how do we tackle those issues?
Do you want me to answer that? So I think there's a huge potential for that to happen. I think we can. I think there's been exemplars. There's been over the years efforts made to try and be enabling, and some of that can be about digital upskilling. You know, people have talked about making broadband available for all as part of things. So there's lots of things that we could do. And I think one of the most important things is checking that people have the ability to do something. And if they don't, having some kind of method to try and make things accessible to them through them digitally, not just saying, oh, well, they don't have it, so therefore you can't get access to care. And it's really important. I mean, it's even the most simple level of digital. Again, somebody doesn't speak English. We have a system, a local clinic service for incontinence, which you had to phone to opt into. So people were sent a letter telling them to phone to opt in an appointment. One of my patients who can't speak English, it took them 2 years to get sorted because they got discharged from the clinic several times because they never opted in via phone. Until one, I mean, I'd written letters saying they won't be able to opt in via phone, and it still wasn't able to. One day I just kind of like rolling, look, this person will never get seen. Can't you just do this in a different way? And they did, and the person did get sorted, but it was 2 years. So that's just outrageous. And it's just by not thinking about the problems people might have and not putting in workarounds or solutions or supports. And I think that we need to look and think about who's going to be challenged and how do we address those. So I don't think it's an insurmountable thing, and I don't think it's not a reason to advance with some of the ideas that we have, but I think we need to put in supports now.
Reflections from any other members of the panel?
Sorry, I didn't quite catch that. Can you just repeat?
Are there any other reflections from any other members of the panel?
I just wanted to come in quickly. I think I'm very lucky in that I have access to these things, and that for me, moving digitally has been a really positive thing. But I think one of the sort of benefits longer term of this is that as somebody who's living with diabetes, I often feel like a burden on the health system, regardless. And sometimes that can be because I can feel like I'm managing really well, things are going great, yet I still need taking up all these hospital appointments. And especially at the moment when, all the information and all the media about kind of the burden on healthcare services, the last thing I want to be doing is taking up time for my healthcare team to have an appointment to tell me that everything's great, everything's fine, yet no problem. So for me, the moving of digital, I hope that what that then creates is more time and more space for our healthcare professionals to spend with people who do need that time. And I can just be a quick 5-minute phone call, great, pass you on, and give that time of my appointment to other people. So I completely agree with Frances that I hope that when we are thinking about this more broadly, we do involve patients to really think about how do we move that time. It's not about removing the time, it's about moving it and using it in the best way possible.
I think that's a really good point. I can tell you right now that I think that some of my patients are benefiting from the teleconsultant, because those who have a very straightforward thing that means maybe a short conversation can have that. And then those who may be more complicated, I may bring them down and we have a longer sit to. And actually, I think there's a bit more potential to be able to do that. So I think sometimes working smarter, can be helpful for both sides.
Thank you both. And I'll just move on to the next question now. This one is from Zoe Fritz, and it says, how do you think the responsibility of the doctor to minimize the burden of decision-making balances with a duty to respect patient autonomy? And do you think there's a way of finding out how the balance for individual patients will work, considering that one size fits all is not appropriate in this? I know that's quite a long question, so let me know if you need me to repeat.
I might jump in quickly, but then I think it would be very good to have Emma or Natasha's perspective on the patient side of things. So for me, it's quite straightforward, because it's about just checking with everybody what they want and what their preferences are. Because I'll have some people, I'll say, well, how would you like to do this and things, and they'll say, look, I don't want to know, you just tell me what you think's best. And yet they'll have other people who very much want to have very long discussions about the pros and cons, and wouldn't be happy with me saying, oh, I suggest you do this. They would really want to think about it and discuss it at length, and might want to go away and get signposted some internet research and then come back and have a chat about it again. So people will vary a great deal. And I think trying to just asking people how do they want to take this forward and what would work best for them is the simple way for that. But I'll defer to my patient colleagues.
I'm happy to go. So I think from my perspective, and it's very much in agreement with what's already been said, but making sure that we have open conversations. And again, they will be tailored to how a patient communicates. So for example, I've had a GP, fantastic, and definitely restored my faith in GPs being invested in the healthcare of their patients. And I'm pretty sure that every single physician is. But I appreciate that a system that squishes a consultation into 10 minutes is quite tricky to, see the person as a whole. But from my perspective, being able to have that open conversation in whatever way it needs to happen, continuing to have check-ins. So if a patient isn't forthcoming the first time, maybe tackling it a different way the next time is helpful. So it's a bit like when you say, how are you? And then pausing and say, no, actually, how are you? Is really important. And maybe for there to be, again, around that, if a physician doesn't get an adequate response through no fault of either party, maybe having a set check-in time. So for example, if a patient hasn't responded in that first consultation with what method would be most suited to them, maybe putting a note in to say, the next time I meet with this patient, let me ensure that I check in with them as to how better to meet their needs. I'm not sure if that made complete sense, but I think so much depends on having that open dialogue. And I mean really open dialogue with psychological safety, where a patient isn't scared of saying, actually, I do need a bit more help, or actually being able to say, I'm really happy with telephone consultations. And again, giving the patient the choice. So I think that's what my concerns as a patient are around, not being able to have the choice for when, so for example, when I'm having an asthma flare, I appreciate this is slightly off the point, I'll be quick. Sometimes things can be missed if it's just a telephone consultation. You can't see the dark circles under my eyes. You can't see how I walked into the room if I'm really fatigued. I compensate really, really well for a really long time until I'm really not okay. And I think, again, it really relies on the comfort between the patient and the treating physician to be honest, but also for those markers to not be missed. So again, tailoring the treatment to the individual dependent on the presenting situation. So my asthma isn't always in crisis, so it doesn't always need face-to-face. But for example, with my COVID consultation, sometimes having a video call, as much as I felt hideous, would have probably been quite helpful rather than just speaking on the phone and coughing through consultations. They may have just been able to take a lot more data from looking at me, for example.
I'd just like to add.
Sorry, Frances, we need to wrap up because otherwise the timings will all go off. Thank you all so much for this really, really rich discussion. For those of you who want to continue, there's going to be a breakout room to continue to discuss these issues for the next 20 minutes. So do please head over there. But on the main stage, I'm going to hand back over to Vivian, who's going to introduce the next session for us. Thank you all so much for joining.